Hello, dears, and welcome to Al-Hussaini Virtual Lab Pathology Talks, tips and practical tips. What I'm going to be sharing with you today is a nice example of a typical teratoid rhabdoid tumor, tyrosinase activated. So this is a case of a 9-month-old female patient who presented with right cerebellar hemisphere lesion. And as you can see here from the low power magnification, the tumor is growing in sheets. It's kind of pink in color, and rather than a blue. Although it's considered to be an embryonal tumor, yet usually a typical teratoid rhabdoid tumor gives this pinkish hue to the tumor at low power magnification. At higher power magnification, the tumor is composed of a growth of those large cells with abundant acidophilic cytoplasm growing in sheets. In some areas, you can see some tendency at perhaps lipoblastic differentiation, but in general, the tumor cells are round with vesicular nuclei and focally some prominent nucleoli. And again here, some tendency at lipoblastic differentiation. And in other areas where you can see the tumor cells, they have this abundant acidophilic cytoplasm, eccentric nucleus, the cytoplasm as if it contains a globule within the cytoplasm. Some areas showing this prominent nucleoli, but usually this is the best area in which it has most of the ATRT morphologic appearance. We have some myxoidish areas in the background, some myxoidish appearance to the background, but then we have some rounded nuclei, some cells with this belly that contains intermediate filament, and these are excellent clues to the diagnosis or to the differential diagnosis of ATRT. Some mitotic figures are scattered here and there, and again, more of the same. Sheets of cells, those sheets of cells have this pinkish background because of the cytoplasm, and then mitotic activity is scattered here and there. And again, in some areas, the prominent nucleolus. Actually, I find it always an excellent clue to the diagnosis of ATRT, the presence of the prominent nucleolus in a small round blue cell tumor. In a way, gives me a hint that this might be an ATRT, large areas of necrosis. Now, given the age of the patient, the appearance of the tumor, actually ATRT should come first in the differential diagnosis much more than medulloblastoma, which is in the differential diagnosis, but because of this myxoidish background, because of the sum of the cells showing this prominent nucleolus in a vesicular nucleus, and because some of the cells show this acidophilic belly-like cytoplasm, ATRT should always come to the differential diagnosis first before medulloblastoma. And if you don't have the immunohistochemistry for ATRT, please use EMA, which tends to show this beautiful cytoplasmic positivity more so than even cytokeratin. So EMA usually is beautifully positive in ATRT, and usually this is coupled with vimentin, which tends to highlight this cytoplasmic inclusion like that is usually containing the intermediate filaments characteristic of ATRT. So if you don't have the INI or BAF47 immunohistochemistry, please rely on a combination of EMA as well as vimentin, and these usually, if positive, would be an excellent support to the diagnosis of ATRT. Now, going on further, synaptophysin was also positive. So as if what the tumor is trying to tell me that the tumor is multi-lineage. It's showing some epithelial differentiation, some mesenchymal differentiation, and some neuroendocrine differentiation. This multi-lineage tumor immunohistochemical pattern would again be very much supportive of ATRT. P53 was not a mutant. It shows this mosaic growth, mosaic immunohistochemical pattern. And then, of course, the SMART-B1 INI1 is totally lost in the tumor cell nuclei in the presence of a nuclear staining in the endothelium, in the background tissue. So remember, you should never interpret INI1 immunohistochemistry unless you have an internal positive control. This is extremely important. Now, because of the age of the patient, I also used the BRG1 immunohistochemistry because some cases, especially in infancy of ATRT, tend to be smart A4 or BRG1 lost with retention of the INI1, but this case is not. Actually, this is more like the classical immunohistochemical pattern. Now, further on, we did methylation on the tumor, and the differential, although the calibrated score is not the 0.9 cutoff that we usually utilize, but remember, methylation, you have always to couple the methylation, interpret the methylation in view of the H&D and immunohistochemical findings. So it was diagnosed actually as atypical teratoid rhabdoid tumor with a low calibrated score, but the copy number variation profile showed the typical loss of the 22q, which is typically seen in atypical teratoid rhabdoid tumor. What was really interesting is that although the calibrated score was low for this tumor, yet it was assigned the tyrosinase activated subgroup, molecular subgroup of ATRT. So I went on and did the tyrosinase immunohistochemistry and came back as positive in this tumor in more than one focus, further supporting the integration of the molecular profiling despite of the low calibrated score into the overall morphology and immunohistochemical profile of this tumor. So the final diagnosis of this tumor is atypical teratoid rhabdoid tumor, tyrosinase activated CNSWHO grade 4. Remember that in a young patient younger than 1 year of age, posterior fossa mass, you have to consider ATRT even before considering medulloblastoma. So this should be always kept in mind. Remember that ATRT in general, although this is considered an embryonal tumor, it usually gives an acidophilic appearance to the tumor on low power magnification, and this is due to the abundance of the cytoplasm containing the intermediate filaments that are characteristic of ATRT. Remember that if you do not have the immunohistochemical stain, the BAF47 or the BRG1, you can use a combination of EMA and Vimentin to support the diagnosis. And remember that methylation profiling of CNS tumors has always to be integrated into the diagnosis in the context of the H&E as well as the immunohistochemical findings. Now, the tyrosinase activated atypical teratoid rhabdoid tumor is actually accounts for around 1/3 of cases of ATRT, usually occurs in infants younger than 1 year of age, typical as in our patient, and these tumors are usually associated with a relatively better prognosis in comparison to other types of ATRT. I hope you find this useful in your daily practice. Thank you.